for our next talk on youth concussion and student-centered return to learn care with Dr. Vavilala as well as Avery Aspen. Dr. Vavilala has over 25 years of clinical experience in taking care of injured adults and children. She has over 400 peer-reviewed publications and is an expert in traumatic brain injury. Dr. Vavilala has developed a program where schools can use to support return to learn after concussion. And Aspen Avery graduated with her master's in public health in epidemiology from the University of Washington shortly after she was hired by the Harborview Injury Prevention Research Center as a research coordinator for a study implementing return to learn for youth concussion in public high schools in Washington. And her research interests include social determinants of health, adolescent and adult mental health, and health equity in public health research and practice.
So Aspen and I are really happy to be here today. This is the second year that we've come and spoken to this group about return to learn. And our objectives for this morning are to just sort of refresh ourselves on the concussion burden among youth, talk a little bit about what's it been like for students who have had concussion during the COVID pandemic, some new data, and talk about our Return to Learn program that we've rolled out in 14 schools across the state, and then talk about how the Return to Learn program may reduce disparities in return to learn care in our school systems. So we'll begin by defining concussion as a mild traumatic brain injury resulting from direct blow or transmission or impulsive force to the head. This is typically rapid onset, short-lived, with minimal or no neurological impairment. The challenge with this definition is that, as you will share with you, the Berlin Consensus Statement doesn't really provide a strong return to learn guidance. So it's a big deal. If you look at boys and girls, respectively, you'll see that 3 different studies have sort of defined concussion incidents to coincide with, in boys, football, hockey, lacrosse, and in girls, soccer, lacrosse, and basketball. And so per 1,000 athletic exposures, you're talking about not a small number of our youth having concussion. And there's a big discrepancy between those who have symptoms and those who actually report concussion. So if you look at the total, the blue bar here, this is 6.8% of children who are 17 and younger who report through this survey ever having concussion symptoms. But the same survey asked about, like, how often have you been diagnosed and treated? It's less. It's not quite half, but it may be about, a little bit more than 2/3, half, right? Because this is 6.8% and this is 3.9%. So if you make this 7 and make this 4, you're looking at almost a 2-fold less diagnosis of concussion, even though folks are having concussion. And this is most common in the older children, so adolescents, 12 to 17 years. But you can see that we do have middle schoolers and elementary school kids and even young children, toddlers, having concussion, and folks don't quite know what to do with that. There's a lot of variation in not only the diagnosis, but also the care and cost. So we did this study looking at, how often families report initiating services, what are the barriers to receiving care, how often there is communication between school staff, all suggesting insufficient knowledge among parents whose children have concussion and lack of school products and services. And then these costs extend beyond medical bills. People are paying for, if you look at costs, traveling back and forth to health visits, sick leave that parents have to take, students missing school, and additional tutoring that, folks are spending resources on. The good news is that concussion symptoms resolve usually within 2 weeks, but about 14% have symptoms at 3 months. And these symptoms include headache, dizziness, balance issues, cognitive problems, emotional issues, and sleep. And remember, during the pandemic, the school system shut down and most of our students were receiving either home education through homeschooling or virtually through screen time. And so sometimes the screen sensitivity was a problem. And, we know that treatment, that we recommend some sort of accommodations or treatment until symptoms resolve. Sometimes that comes at a cost of sort of sacrificing academic achievement. And we've been spending some time thinking about how do we evaluate what role, this plays. So the current state of treatment for return to learn is you have an initial period of cognitive rest and then a gradual increase in stimulation as tolerated by the student. This really requires collaboration between family, healthcare providers, and school personnel. Sometimes these accommodations are reduced workload, rest breaks, frequent reassessment of symptoms, and limiting environmental stimulation. And then there were recommendations before we started the study that we're going to talk to you about, recommending adjusting accommodation based on symptoms, but nobody had really looked at that or tested that. If you're getting a sense that there are these recommendations, but implementation is, not always consistently done, that's true. And in addition to that confusion, these different societies recommend different things. The language they use in terms of their recommendation varies. So the American Academy of Pediatrics says rest is recommended, but doesn't really talk about how long. The American Academy of Neurology doesn't really, it actually says there's no adequate data to make a recommendation, and so on. And so, but the commonality between these is that some degree of cognitive rest is, I think everybody agrees that's important. How long that should happen is not clear. I would say most people land today around the fact that you need rest if you're not able to tolerate the cognitive load that students experience. And, those of us in the clinical setting will know that, if you injure your ankle or some other part of your body and it's not broken and there's a sprain, you kind of like stay off your foot for a while and then gradually increase weight bearing, load bearing as tolerated. And in some ways, this is very similar. We're landing around, you have a concussion, it's invisible, first of all, so people don't recognize it. And then the cognitive load, the exposure to thinking requirements, to light, to other processes, may need to be sort of dialed down if your symptoms are getting worse. So Washington State was the first state in the country to pass the Zach-Lysted law, which required students to sort of stop playing if they've had a concussion and then gradually return after seeing a professional. This was really groundbreaking, and all 50 states in the country have a return to play law. So athletes really cannot return to play until they're evaluated by a licensed medical provider trained in the diagnosis and management of concussions. Now, there's some conversation around disclosure and what are the encouragements and incentives for students to go back to play, and so all of that is still an issue. At least we have a law on the books in all states. There is a new law effective September of this past year, House Bill 2731, that was passed in June 2020, but really not implemented until September 2022, which requires public schools to annually report information about each diagnosed concussion sustained by a student during athletics or other activities. So there are minimum reporting requirements such as student's grade, event date, location of injury, etc. And so this is part of the RCW, so it's hardwired now, and the Department of Health is collecting information on concussions across the state. I think where this law kind of fell short, in our opinion, is that knowing that we have a return to play law, now we have a concussion reporting law, how are we supporting our students in schools beyond just the reporting of the numbers? And this is where the return to learn information and programs are important. These are states with return to play laws, right? All of them. It's all dark purple. But if you look at return to learn laws, fewer states have return to learn laws across the country, and Washington State does not have any formal guidance. Again, the recent law requires schools to report numbers, but there's no accommodations law or treatment plan. And yet, if you look at what parents think, and this is a survey of parents of children 4 to 18 years, over 1,000 parents provided input. 50% are worried about concussion, particularly our Black, Hispanic, and less affluent communities, which are often less plugged into receiving healthcare. Also, there are concerns about standardized helmets, maintenance of helmets, and other issues that may make receipt of care, including diagnosis, challenging. 96% believe parents should inform schools of concussion. 92% of parents felt RTL should proceed, return to play, RTP. So the priority has been on return to play. Well, we want to learn before we play, right? I mean, at least academics needs to be prioritized, and this is what parents felt. Most felt schools should provide some kind of RTL adjustments. Now, of course, those of you who are in schools will recognize this kind of adds another burden to school systems who are already charged with doing so much without any additional funding. So this RCW that was passed in the state does not provide any added financial plans for return to learn, and so that's why we don't really have a statewide plan for this. So the sources of problems as perceived by parents are poor communication between healthcare providers and schools, disagreement regarding return to learn decisions, like who's diagnosing, schools don't want the responsibility of making that diagnosis, and lack of teacher involvement hampers return to learn care. So there are 4 freely available best practice return to learn protocols out there, and these are recommended by the CDC as examples of programs that could be adopted by school systems, but they have limitations. For example, some of these programs don't really address symptom duration support. How long should support be provided? Some of these programs don't really talk about how well schools should adhere to the plans that are proposed in these guidelines. But nonetheless, they do exist. For example, Brain Steps in Pennsylvania has a really robust system of state-funded consultation. It's paid for by the state. You're in a school, you have a concussion, there's somebody, who's received online training to support you, and that requires resources. So again, we're talking about our state, and this is lacking. So if you were to think about what are the essential components of a return to learn protocol, so let's say that we don't have a statewide comprehensive program where there are athletic trainers in every school, and every school has a school nurse, which we don't have. These are some things that are considered essential. So we should have theoretically some way to identify, screen, and assess return to learn needs. There needs to be some way to communicate between medical and educational systems, some way to track student performance, academic achievement, and cognitive well-being over time. Teachers and other school personnel should have professional development in this area, and there should be some outcome measures developed. Now, everybody's burdened by the need to take more trainings, and that's another challenge as well. Something we learned is that when the trainings are too long and too complicated, it's just another barrier for folks. So the best practices, so along with those 5 essential components, we know that return to learn should be gradual and customized, as I mentioned earlier. There should be some monitoring of progress. Students with prolonged symptoms should see a specialist, and screen time should not be entirely banned. Again, just in support of this ankle sprain analogy, take some rest initially and then gradually get back to it. So I'd like to just turn over the presentation to my colleague Aspen Avery here from the HIPRC to continue this conversation.
So I'm going to transition and speak the rest of our presentation on 2 studies here that were conducted at HIPRC that were around return to learn in Washington State. This first study was really aimed to understand RTL accommodations and RTL school policies in place, along with perceptions of student struggles among high school students during the COVID-19 pandemic. And we wanted to look at this across the different learning environments as well. So we administered a repeated cross-sectional analysis study and did surveys to school representatives, primarily school nurses and athletic trainers, in the height of COVID-19, so in March of 2020. Our second time point was in April of 2020, followed by a year later in March of 2021. Our sample included 21 Washington State public high schools. Primarily, we learned that schools changed learning platforms across the study period. So in the height of COVID-19 in March of 2020, there was no school, and then schools quickly adapted to an online platform by April of 2020, and by March of 2021, schools switched to a hybrid model where some students would go in person and some days they would be virtual. By March of 2021, we looked at accommodations given to students with concussion and found that around a quarter of our sample did not provide any accommodations to students. So if we look at this figure on the bottom right, the red boxes represent categories of return to learn accommodations, and the blue boxes represent RTL policy in place at the school. So we first see is that there's a lot of white space. We see a lot of our schools did not provide RTL accommodations. Secondly, if we look at the blue boxes, we see about a third of our schools did not have any RTL guidance in place. And following with that, comparing policy to accommodation provision, we see that there is no association with RTL policy with providing academic accommodations to students with symptoms. So that was a major finding in this study. We're seeing that schools really were struggling to provide accommodations, and even if they had RTL policy in place. We further evaluated students' perceptions of students with concussion to see if they felt like they were struggling more during the pandemic, and we found that they did prior to the COVID-19 pandemic, as well as RTL accommodation provision was associated with larger student body number and graduation rate. So overall, we saw these schools quickly adapted to alternative learning environments during the pandemic, but this did not follow with providing RTL accommodations. So the schools really struggled providing accommodations to students, as well as following up with symptoms was very challenging for the schools. This was due to COVID-19 pandemic, also with the influence of online environment, making barriers to check in with students. Following, there was considerable variability in the type and number of RTL accommodations provided within the school. Also, schools across the size, demographic, and funding spectrum struggled to provide RTL accommodations despite the existence of RTL policies. So generally, Washington State, we learned that guidance for RTL accommodations is lacking. Although we did find that RTL accommodation provision was associated with larger student number and graduation rate. This may be due to larger resources larger schools may have compared to smaller schools. So this may lead us to think that students from smaller rural schools that have less resources are especially at risk for not receiving any return to learn care at the school and may further worsen or prolong concussion symptoms for those students. And on top of the symptoms that students with concussions already experience, including emotional and cognitive symptoms, we still don't know what happened to their mental health during the COVID-19 pandemic. So next I'm going to transition to our Return to Learn study. This was led by Dr. Monica Vavilala, who is the PI on this study. This study was a CDC-funded study. It was scheduled to be over the 2020-2021 academic year, and COVID-19 halted that. So this study was conducted over this past academic year. And this study had three primary aims. First aim was to determine the effects of RTL bundle implementation on RTL program quality. So really seeing if the schools are able to adopt our RTL program and successfully engage students in the program. Our second aim was really to determine school factors associated with achieving RTL model implementation. And lastly, we examined the effects of RTL model implementation on student outcomes, such as days to initiate RTL program and days to full return to learn. So this study, we used a convenient sample stepped wedge study over last academic year and included Washington public high schools with more than 50 students and no formal RTL program or policy. We grouped our sample of schools into 3 blocks, and the blocks of schools received the intervention at staggering time points. So we recruited 28 public high schools, and 14 of those participated throughout the academic year, and those schools received what we call the RISE bundle intervention, which includes first a 6-week process to adopt, implement, and sustain an RTL program. So each school had an RTL champion identified, which was the school representative responsible for implementing the RTL program and engaging students in the RTL program. So the majority of RTL champions in our study were school nurses and athletic trainers. We did have a few administrative staff be the RTL champion, as our program does not require any medical expertise. Secondly, the RISE-Bound intervention includes a toolkit, which we call the student packet, which really involves guidance and tracking on student progress and for developing that communication processes to share concussion management information across the school, student, parent, and health providers. We also provided school support along the study period as well. So I'll share a little bit about our student packet, which is really the RTL program that the champion involves students with concussion with. So this involves weekly check-ins with students who sustain a concussion. We first collect student information, injury information, as well as parent-provider contact information, to build the beginning communication links. Secondly, the student packet involves symptom checklists. So it involves a pre-injury symptom checklist as well as a checklist to be administered at each check-in. And this is really used for longitudinal tracking of that student's symptoms. Our checklists are broken up into sleep, physical, cognitive, and emotional categories, as well as includes instructions on actions to take regarding duration and severity of symptoms. Our third component of the student packet is really those temporary recommended accommodations. So this is what the RTL champion recommends the student needs. And these accommodations are also broken up into sleep, physical, cognitive, and emotional categories. In this way, the RTL champion can tailor each accommodation to the symptom. So this is really unique about this program, is that each accommodation and concussion management for that student is a standard guidance, but it's tailored for that student specifically. And lastly, our student packet builds communication processes to share information and update teachers, parents, coaches, and providers on the symptom status and accommodations that student needs. So all this built together, it's really a tool to help do a longitudinal documentation and tracking for that student, specifically to keep track of student symptoms and when the student is ready to full return to learn. So our study launched August 30th in 2021, so beginning of last academic year in 14 public schools. So if we look at this map here, we see we had a variety of schools across Washington state. We had schools on the western side, central and eastern Washington. We also had a large range of school sizes. Our smallest school was around 160 students, and our largest school was over 2,000 students. So we have a variety of school sizes, as well as the red dots represent rural and the blue represent urban areas. So we also have a wide variety of school locations as well. So across the study period from our 14 schools, we had 236 reported concussions. And if we look at this top graph, we see that schools with larger student count had larger numbers of reported student concussions. Our bottom graph shows the number of student concussions by month. So here we see an increase and a peak in reported student concussions during the fall months. We think this corresponds with fall sports such as football. Then we see a decrease during the winter months, as well as an increase in the spring months as I think soccer's in the spring months as well, with increased reports of student concussions. So next, this table shows the characteristics of our 14 participating Washington public high schools by RTL program establishment. So we defined RTL program establishment if a school completed the 6-week RISE bundle implementation and engaged students in the student packet across the academic year. So among our 14 schools, we had 10 schools that successfully established the RTL program. So schools that did not establish the RTL program were more likely larger schools in urban areas. This may seem counterintuitive, as we saw larger schools may have more resources to engage students in a return to learn program. But then we also see these larger schools with heightened number of concussion reporting. So they're still seeing a lack of resources to engage students in concussion management. So following in this study, we also evaluated concussion knowledge among our RTL champions. So we administered a survey at the beginning of the study as well as the very end of the study. So at the beginning of the study, we learned that generally the concussion knowledge was very low among our sample. So schools didn't really know, what the objectives of a return to learn plan are. They did not feel confident in knowing what academic accommodations to use, also delivering academic accommodations and communicating concussion management to stakeholders. So if we look at the end of the academic year among RTL champions that established an RTL program, we saw the largest increase in concussion knowledge among those RTL champions. So this shows us, the RISE bundle implementation and really implementing a return to learn program at a school increases concussion knowledge. And we did not see as high an increase in concussion knowledge among schools that did not establish a return to learn program. So next, this table shows reported agreement on RTL program assessment questions. So among the RTL champions that established an RTL program, we asked kind of questions on how they believe the RTL program engaged with their students, if it increased concussion management and provision of accommodations. So overall, the RTL champions believe the program increased their school's ability to provide concussion care for students, as well as they believed the program reduced variation and inequities in concussion care. Overall, our big finding is that we believe if we implement a standardized evidence-based RTL program, it could promote equity in concussion care and potentially reduce disparities in adverse outcomes among students with concussion. So overall, the Return to Learn study, our primary finding was that the RISE bundle was found to be feasible to implement a Return to Learn program in rural and urban high schools of varying sizes. The RTL program also increased provision of tailored academic accommodations and increased concussion knowledge at the school, particularly in providing tailored academic accommodations. And so our biggest implication from this study, we think implementing a return to learn program in schools could reduce inequities in concussion care and RTL management at schools. So I wanted to end this presentation with a video we generated for Brain Injury Awareness Month. And this video includes information on our RTL program and testimonials from RTL champions.
Concussions don't have to be a mystery and they don't have to be scary. They're not something that is necessarily life-ending or career-ending.
There's a large number of students who have concussions from sports. We developed a Return to Learn program that tailors accommodations to symptoms, and we are piloting this program across public high schools in Washington State.
It's provided us with tools to help increase communication, to help make sure concussions are managed correctly, properly, and that students return to the classroom and then return to sports.
That takes the guesswork out of what comes next for both the families, the students, and also for the teaching staff, and reduces the anxiety that the students are experiencing about how to advocate for themselves.
And by removing those barriers, by implementing a return to learn program, you're really able to see concussions get managed properly and a full recovery on almost all kids.
If your child is a student, or your partner is a student, or you're a student and you have TBI, then you should have your symptoms evaluated.
When they're managed well, concussions, you can have a full return to things that you normally love doing after concussion.
Your brain is really, really, really important, and so treat it that way. And just because you can't see it doesn't mean that it doesn't need the love and attention that every other part of your body gets.
Happy to take questions. Please feel free to ask in chat or aloud.
These are the questions that we've been sort of collecting along the way. Is there any law or work towards guidance requiring return to learn before or simultaneously to return to play?
So there are some laws across the country, but none in Washington state. And I think that's been our focus, is how do we try to work with our policymakers and to raise funds and to sort of direct funding so that we can have an RTL before RTP in place.
Okay. And is the new law only for concussions sustained at school and or during school activities? Do we report concussions sustained at home or outside of school?
Aspen, do you want to take that?
So the law is vague in its language, so it was variable in how the Department of Health generated their reporting tool, but they do want to collect data on diagnosed concussions sustained at the school and other activities, including other activities at the school or outside of the school. Such as if a student is in a car accident or is in a skiing accident. So they do collect that as well.
We don't really know what the concussion burden in the state is. I mean, I think that's part of the problem. And concussions, the diagnosis of concussion can enter the diagnostic realm in urgent care clinics, emergency departments, primary care clinics, schools, or, not at all. And so this is one way to try to get at that. Back of the envelope calculations based on the data that Aspen provided, suggest that there may be 10 to 20,000 students, high school students a year in the state who have concussions but don't have any treatment at all. That's a large number. And so I think this is one step. So they're trying to get a handle on, like, what do we become aware of in the school setting, regardless of where it happens. Aspen, would you agree with that?
Yes, I would agree. Mm-hmm.
Can athletic trainers decide when a student can return to play or only a licensed medical professional?
Yeah, that's a good question. I don't know the current rules on that. If there's an athletic trainer in the audience, I'd be happy to defer that to them. I believe it's a license. I don't know, actually.
I believe everyone is a nurse on the call, so maybe we can try to find that information.
Yeah, I mean, I think
it's a
I think it's a licensed medical professional. That information has to be communicated to the athletic trainers, but how that's actually rolled out, I'm not clear. Okay, so Cindy Welsh has a comment. Yeah.
Okay, so athletic trainers, if they have the training.
And I don't know
What are
what
the
that
criteria?
training I don't know what that training
ahead.
looks like. Cindy, do you know what training they need?
Cindy says she does not, but she can find out. Oh, sounds like it's a kind of a gray area.
Yeah. Which is why I'm confused myself.
We know a lot of students that we saw in the study. Not every student sees a medical provider and has they're only receiving care from athletic director or nurse. So in that sense, I think if they're trained, they can do return to play.
All right. Next question. What are the criteria for a coach to suspend and refer for suspected concussion?
Yeah, so I mean, I think obviously if you have a mechanism, right, like a hit or blow to the head, any loss of consciousness, any symptoms, memory loss, seizures, headache, I think that necessitates some evaluation.
All right. How do you help educators who struggle with understanding invisible illnesses and conditions to believe their students' reporting of their symptoms and needed accommodations?
Yeah, that's an interesting question. I'm wondering if the person who asked that question is asking because people don't believe when students complain of concussion. Is that the reason the question is being posed? I mean,
Yes.
is that a real thing? And so what do you think people complain? So could you educate us about that?
I think that there's an undercurrent in educators who believe that students are attempting to avoid work or to essentially they're faking their symptoms in order to make it easier for them. And this isn't just for concussions. This is for migraines. It's for any kind of chronic illness. It's got like brain fog or things like that. So it's not just concussions, but it's
And so I
there's
guess
just a lack of trust there.
yeah, I guess it's you can't sort of argue with a broken bone, right? Or something that's in a splint, but
Yeah, this is an interesting question because this is some feedback from that we received from the RTL champions. It's kind of the struggle with, you know, suggesting temporary accommodations and teachers because they're the ones that kind of have to follow through on majority of those accommodations. So their feedback is some teachers there's kind of a gap between what their suggestions and they believe what the teacher's actually providing the student. And there's couple suggestions was just more intense concussion training for all personnel at the school, since it's kind of all, you know, a teamwork at the school that's involved with that student. But this is I think a great question.
Yeah, I think it also it reaches into that concept of a dynamic disability in that the symptoms are not linear. They may have something more on one day than on another day, and things that they used to struggle with get better, but then they come back maybe. And that's just something for people who are able-bodied and don't experience it, very difficult for them to understand.
Mm-hmm.
and I think it's also hard to separate mental health concerns from, you know, the concussion symptoms, and maybe they are related sometimes, and that makes it problematic as well. I guess I would, is there anyone on the call who actually has used our RTL program? If there is, could you comment on whether did use of that program help with sort of addressing this dynamic disability issue? Polly Shems is showing thumbs up. So maybe could you speak to that? Because we didn't really receive that kind of feedback.
Yeah, so I got into the study early on, but wasn't able to do it this last school year because of my involvement with COVID at the district level. But I I can agree that so I'm at a high school. I have had teachers question, how can you tell me how to run my class? How can you tell me that I need to modify? But it's parallel conversations that I'm having with family, with student, and with the teachers. So while accommodations are temporary, I tell the student it's not a golden ticket. They're not getting out of class. They're not getting out of the semester. But it has to be mutually agreed on. And since, let's see, so I've been in the high school now 8 years. So since that first year, I usually do a blurb at the beginning of every year explaining concussions and recovery. And I think it's a lot of education that's needed for teachers, for the student athletes, for the families. And I have found that the tool really breaks down the symptoms, the accommodations that are needed. And I have found over the last couple years of using the tool that the pushback I've gotten from teachers has been less and less.
Well, that's great to hear. What would you mind sharing what high school you're from?
Oh yeah, Gig Harbor High School.
Great. Well, thank you so much for sharing that. So if any of you is interested in kind of using this tool, please contact us. So I think Susan Borst is saying this is really helpful, this tool. Great. That's wonderful. So I want to, yeah, so I think there's some other questions. Should I read the chat box
there's a
or
lot.
no? Okay.
Oh, why don't we direct the questions to the to the Mentimeter if possible, because it's really busy in the chat. And whoever just came off mute, if you want to just finish your thought, and then we can move on to the other questions that were submitted.
Sure, my name is Cindy, and I'm here at a high school level also, and we use this all the time. We used it a lot during football season, and the nurses, we got it set up to where the student would come in the morning and check in with the nurses, and we would send out an email to all of his teachers or their teachers that they would have during the day, stating that we're watching for concussion side effects, list them out. We did list a few of the things that we could possibly do, like dim the lights, dim the computers, those kind of things on that email as well. And then we just put in there, if you had any questions, to contact us directly so we could go into more detail with that. And then we're lucky enough to have an athletic trainer on site as well. So at the end of the day, the student would go in and check in with the athletic trainer, and we would decide whether we would shorten days, whether we, how things were progressing. So that really helped with a lot of kids. And we had some kids that were back in a week, and we had some kids that were out half days for like 2 weeks. So it really depends on the student, but it did help.
You. Yeah, thank you. And I mean, am I correct that there are 42 questions? Is that right?
Oh, those are total, including the
Okay,
other
okay.
talks. Yeah, but
Okay.
I'm going to move on maybe to the next one.
Sure.
The RCW about reporting is currently written to only apply to concussions that are medically diagnosed and occur in school event. Do you think this will change for a bigger picture of data?
Yeah, I have no idea how to answer that question. I just don't know. I agree with you. It's sort of, the liability of diagnosis of concussion is one issue. And so I don't think schools want the liability of making the diagnosis of concussions that occur outside of school. But I think some schools that are, for example, participating in this RTL program would like to be able to manage the students for the time period that they're in the school.
Mm-hmm. It says the new law says our athletic trainers' assessment and positive identification of concussion are not being counted in any data set. Only MD diagnosed are being counted. Can you comment?
Okay, so that's something we can take back to our DOH work group, because the DOH work group that actually supported how the rollout of this law has athletic trainer representation, strong athletic trainer representation. So we participate in those conversations. We will take that back to DOH. Thank you.
Right. And then who determines individual accommodations in the RTL program?
Yeah, so that's good.
Yeah.
Yeah, that's great. So just so you know, this RTL program was sort of developed by UW Medicine and Seattle Children's Hospital physicians, vetted by the Attorney General's office here at UW Medicine, and the schools that it's evidence-based, and so the accommodations were derived with, I would say, expert input. Now, I'll let Aspen speak to this specific question of which accommodations in the program are provided to students and how.
Yeah, so the RTL champion is primarily responsible for recommending accommodations. Some students have, see medical providers that as well recommend accommodations. So our protocol is really adaptive in the way where the RTL champion can incorporate the medical providers' suggestions on accommodations as well as their own. And this accommodation is really built on their symptoms. So we have a mapping system of where accommodations are. It's primarily guided accommodations based on student symptoms. Did that answer the question? I did.
Okay.
Yeah.
Was this study just for sports-related concussion, or did it include other types like motor vehicle accidents?
It included other types. So all diagnosed concussions. I think primarily our study from the reported concussions, around 75% were sports related. So around 20, a quarter were non-sports related. So that was also a finding that we found was interesting.
Great. Then at schools, how do you work with special education students where communication to assess level of concussions or symptoms or effects cannot always be assessed accurately?
Yeah, that's a great. I don't believe we had experience of that during our study, but I think that's a great question.
Yeah, that's correct. I think we were focused mostly on mild TBI. I think and concussion, not, the more severe symptoms. So that's one aspect of the answer. The second aspect is people who have pre-existing conditions where mild concussion can be exacerbated. And Aspen, I don't actually know if we know. Actually, we do know. We have the data on how many of our students have pre-existing comorbidities. And I'm just wondering if we can go back and look at our data and find out how many students did we support who are special ed kids.
That would be great to find out. And then does the WAC requesting to report concussion apply to childcare?
That's a good question. I don't actually know. I don't think it says that. But some child cares qualify as like educational facilities. I don't know if that's true. We will ask that question to DOH.
Thank you.
Thank you.
Then at what point should students with prolonged symptoms see a specialist?
Right. So we have a protocol for a 4-week timeline as part of the RTL program. If you're having symptoms past, obviously if symptoms are worsening, or if you have persistent symptoms after 4 weeks, you should see a specialist. Now, I will say there are a lot of concussion clinics out there that have that have come up with increasing awareness of concussion. So I would say it's good to go to a reputed concussion care program. So I think if you're interested in participating in this RTL program, we would encourage you to contact us. We'd like to sort of work with you because it's not just about disseminating a packet. It's really a coached process. The state I think there was a group in the state a few years ago that released some written materials to use, and that material was disseminated across 135 schools with very little uptake because it really does need some data-informed practices and optimization. So please, I think Aspen has put our email addresses or the link to the Aspen, did you put the RTL email address or your email address in the
I put
chat?
mine.
Okay, is that what you want? Yeah. Okay, and we also put the web link to the website, right, where more information can be retrieved. Is there a cost?
I think this might be in your slide deck potentially too, which was sent out to people.
Okay, great. Yeah, I mean, we're a small organization, right? So we do have, I think it's a very nominal cost to participate. Aspen, do you want to speak to that? I mean, and we do kind of make accommodations for school districts that, can't really afford it.
I think right now it's licensed at 500 for the academic year, and then it's variable on if a district is wanting to adopt it and how many schools within that district. So it is variable, but our standard, I believe, is 500 per.
So I think I think the advantage of this is you have somebody who's available to walk you through the implementation process, and you also submit the forms online, so we can give you back your data, so you can see what what accommodations you have been making over the past year, what accommodations are needed, what is the mismatch between symptoms and accommodations. And we're actually in the middle of analyzing our data from the 14 schools on symptoms and accommodations. And if schools really pay attention to concussion, there will be a large number of accommodations that schools will end up providing students because the need is so large. But if this toolkit can help make that better in a relatively easy way. I think each interaction with the student takes about 10 to 15 minutes, and it's a very short period of time. It's electronic, so submission, completion of the forms. So I think the real benefit here is your organization learns also. I'm wondering, I don't know if we have time or not, or if this is the last question or not, but I'm wondering, Aspen, if we can kind of give an example of the kind of data that Eric Phillipson's work will be showing, just so they understand why this is important to collect the information on accommodations being provided.
Yeah, I don't have the mock tables with me, but the information that we'd be able to report back to you is the number of student concussions kind of broken down by student demographic characteristics, as well as a record of what accommodations were provided, the length of the return to learn program, so how long that student needed accommodations prior return to learn, as well as severity of symptoms.
So I'm going to put a link to an article that we published based on some preliminary work. But if you are able to access that, I think it would be helpful to see how we're evaluating the mismatch between symptoms and accommodations. This is in Washington State.
All right. Well, thank you so much for your presentation and your talk and all the research that you're doing.
Thank you.
Thank you all for your wonderful engagement and interest, and we look forward to hearing from you so we can support this work and our students.